Ma'am,
We are,
should we?
yeah, should, yeah.
Right. Here we go. Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 9N, which is Cytopathology. And we are streaming live from the Basavatarakam IndoAmerican Cancer Hospital and Research Institute, Hyderabad, via Kolkata. And a very interesting topic and an excellent person to moderate. Let me introduce the moderator. She is retired Major General Dr. Reena Bharadwaj. She's presently the senior consultant in oncopathology at the famous Indraprasth Apollo Hospital. With various awards and achievements, to name a few, she has been awarded the Sena Medal and the Vishish Seva Medal, awarded by the President of India. Also the Chief of Army Staff Commendation Award and the General Officer in Charge Commendation Award. So I would request ma'am to take over and introduce the speaker. Ma'am, please introduce the speaker and start.
Thank you so much, Dr. Nadeem. It's indeed an honor and a privilege to be chairing and moderating this session for my dear student, Dr. Harveen Kaur Gulati. She has a long association with me. She did her MD Pathology at the Armed Forces Institute of Medical College, Pune, in the year 2008. And Harveen very quickly decided that she is in love with oncopathology and went on to do a 1-year certificate course not only in onco but also in molecular pathology. And then she took special areas of interest in cytology, oncopathology, gynec path and molecular path. So she then realized that that was not enough. Her passion for the subject grew and she decided to have more diverse interests, which are very important. She did an advanced course workshop in medical education, technology, and in quality management systems and internal audit in medical labs. So for a person to be an all-rounder, you really need to do all this in addition to your focused areas of interest. And she also wanted to come on to the national platform for her quest for knowledge. She soon became a member of the IAPM and the Indian Academy of Cytologists, went on to be in the International Society of Gynaecological Pathology, and is a life member of Molecular Pathology Association of Pathologists. Personally, I have known Harveen very well. She's a very smiling person, very bright, and a lovely human being. So with that, I will hand over the mic to her. She is currently the senior consultant pathologist at the Basavatarakam IndoAmerican Cancer Hospital and Medical Research, and she will be talking to us on the role of cell blocks and preparation and interpretation. Over to you.
So may I share the screen?
Yeah, just present your screen, ma'am. Yeah. Your entire screen, yeah. And then share. Click in the center and share. Yeah, we can see your screen coming. Yeah, just open up your PowerPoint.
Yes, sir. Can you see my screen, sir?
Yeah, make it full screen. Yeah, and just press that hide thing there.
Okay. First of all, at the outset, I would like to thank Dr. Nadeem, sir, for this opportunity. And what to say about Dr. Reena Bharadwaj? She has been my teacher and my guide throughout, and we always used to look up to her for everything. Thank you, ma'am, for the kind introduction. So, without further ado, we will start off with the presentation. So, my presentation is on role of cell blocks in cytopathology, its preparation and interpretation. So this is my institute. So this is how I have planned out my talk. After a brief historical introduction about cell blocks, I will go into the technical aspects, which will be followed by utility of cell blocks in diagnostics, prognosis as well as therapy. And I would like to try to make it as much as case-based discussion so that it is interesting. So, if we go into historical aspects of cell blocks, so initially the microscope was discovered in 1660s to 1670s, and cell was discovered by Dr. Robert Cook. After that, the first ever cancer diagnosis, came in 1882. Why was there a big gap between 1600 to 1882? This was because there were dark ages. Like there were certain pathologists, certain people like Dr. Morgagni and all, who didn't want to, undertake microscopic examination. They didn't believe in that, and that is why it didn't flourish. Then the cell block per se was first in 1896 with celluloid embedding. Then centrifugation was introduced in 1901 to increase the cellularity of cell blocks. This was followed by various materials were used to bind the cells together so that they can be, introduced into a cell block, and it can be cut by histological section. So various things like bacterial agar was used. In 1973, plasma thrombin plot method was introduced, and this almost remained stable till 2007 when Celient or Holojet introduced automatic cell block system. So the technical aspects. So what are cell blocks? Cell blocks are nothing but they are concentrating techniques with or without a supporting medium to form a compact mass. Now this compact mass that can be processed at routine histopathological sections. So in this era, it becomes a important diagnostic tool where minimally invasive procedures are there. The biopsies are becoming smaller and smaller, and in the same era, the cell blocks play an important role. And someone has rightly said that they form a bridge between cytopathology and histopathology. So as we, in a cytopathology lab, when we receive samples, these are the kind of range of samples which we can receive. So unlike histopathology, where the thrust at the sample collection level is majorly at the OT, and similar procedures are followed. Everyone uses formalin fixation. There are varying samples in cytology, as well as we can see that various ways in which the samples can be processed. There can be air dried smears, which can go into for pap staining, air dried smears for Gimsa staining, alcohol fixed smears for pap staining, and so on. So this is how we keep processing. So these are these are a few ways in which we process. If it's a fluid, we will do a cell count after seeing the gross appearance, and then presence of any coagulum. If it is there, we will try to put it in the cell block. So these are the various methods which we use. I'm not going into detail. We will come to cell blocks. What are cell blocks? There are in technical aspects there are 4 crucial steps for cell block preparation. First is the fixation. The cells are fixed as needed for subsequent applications. So many fixatives are used. I'll I'll talk in detail about them in subsequent slides. Then with cell concentration methods like sedimentation and most importantly centrifugation is used so that the cells in the suspension can be concentrated into a solid mass or a pellet. And these these cells then can be supported by a medium, which can be either a clot or a alginate or agar or any histogel or anything. It can be it is made and then it is processed like a normal routine tissue processing. So what about fixation? The difficulty in cytology is that many fixatives are used, and there is no good common fixative which is used everywhere. Every lab and every hospital use different kind of fixatives according to their own lab practices. For example, a normal saline can be used. The advantage is that it provides flexibility. Okay, but if the sample is kept in normal saline for a long time, the cell integrity can be lost. And then RPMI medium specially is used for flow cytometry. Formalin is widely used for cell blocks, but and it is also validated for IHC and molecular techniques. But crosslinks can be formed which can interfere with DNA extraction and can cause fragmentation. And there are many alcohol-based techniques. The shore path and the liquid-based cytology preparations usually have alcohol, which can be methanol or combination of various alcohols, and these are quite comparable to formalin. And because formalin causes cross links, it can interfere with DNA extraction. However, alcohol-based fixatives are better for molecular tests. But for IHC, formalin plays a better role. So, is there a way out? Some people use combination of formalin and alcohol. So what has been recommended by CAP for molecular testing is that do not use fixatives like Zenkers, B5, B+, acid zinc, formalin, and Boyne's fluid, or any decalcification fluids. We should not use because they have acids and they can damage DNA irreversibly. So this is a flowchart which shows that what kind of fixatives have what effect and what all tests we can do if we use that kind of fixative. So if we see that for cell blocks, all the smears are fine, but for karyotyping, if you want cell cultures only, we can't use smears or formal fixation. Only RPMI material or normal saline can be used for karyotyping because we want the cells to grow. So there are many methods which are there in the literature, and they have been divided as gel-based methods, where a gel-like material is formed which holds the cell together. The material can be gelatin, agar, or they can be proprietary gels like histogel. And then there are coagulation-based methods. So the most commonly used method here is the plasma thrombin method. But there are chemical-based coagulation methods like alginate calcium method, which is widely popularized by Indian Academy of Cytologists, and they recommend the use of sodium alginate also. There can be other preformed supporting medium. They can be proprietary material like nanonex or micronex or colloidal methods. They can be used. Sometimes we have smears, and then there is a requisition from the clinicians that we need to do some other tests, molecular or IHC. So from the smears, we can scrape the material, or millipore filters can be used so that we can make cell blocks. So as I told you, alginate and calcium method has been propagated, and what we use in our lab is either a plasma thrombin method or a formol alcohol method. So what is the principle of plasma thrombin method? That it is basically it is a pellet is formed, and a clot is formed when plasma and thrombin are mixed, and in that clot the cell material can get trapped, and this can be used in all variety of FNA samples which we get in the laboratory. So this is what we use here. Like these are the materials which we use. This is a thromboplastin which we use. It comes in a powder form, and it is reconstituted freshly when we have to use it. So basically, after centrifugation of fluid, cell pallet is formed. The supernatant is thrown away into the ETP contained waste basin, and after removing the supernatant, the sediment is collected in one tube, and the sediment is then we add plasma and thrombin. So the ratio of plasma and thrombin is plasma if it is 0.5 ml, the thrombin has to be 2 times, right? So it's always in a 1:2 ratio. The plasma is 1 and the thrombin is 2 times. And we also add formalin, and after adding all these things, we centrifuge, and allow the clot to be formed. This is how a clot is formed. It changes its color, and there is a pellet sort of a clot which is formed in the upper part as well as in the lower part of the tube, and this is taken out and um, uh, taken out with the help of forceps, and it is used for embedding. The other method which we use is a formol alcohol method. Here we make a solution of or formalin alcohol mixture which contains 1 part of buffered formalin and 9 parts of ethanol. One drop of eosin is added to identify the fluid in the rock and also to color the cell block material so that it is visible during cell processing. So the resulting clotted sample is then processed like routine as routine sections. There are other newer techniques which are there like the histogel method, the cytoblock method, and in 2007, as I told you, the Celient or hologic method. They are basically liquid-based membrane-based filter method. Here they put a membrane and through which a pressure is passed and all the cells get attached to one filter, and then that is processed and a cell block is formed within 1 hour. A cell block is formed. So this is a comparison of various cell block techniques which have been used in literature. But most commonly everywhere we see that plasma thrombin has been used because it is suitable for all the kind of samples and all the kind of additional tests we want to do. It is simple, it is low cost, it is easily available. It can be done in any normal lab which is there. So automated processors causes minimal cell loss. So when the cellularity of a fluid is less, we can go in for hologic method. But disadvantages are because it has alcohol, usually as a fixative, IHC results can be uh, erroneous. Then agar method is can be used, but it causes even the histogel method requires heat to melt the gel, and then it is put. And this heating can introduce a lot of artifacts. So this is also not suitable. It can alter the morphology also, and various other techniques. And then Siddham's method can also be used. Now the important point is that we can use any method, but we need to validate our immunohistochemical stains or molecular tests. With whatever things, if we are validating it, we are able to validate it with the standard methods, then we can use any method. So now we come to the third part of my talk, which is the utility of cell blocks in diagnostics, prognosis, and therapy. So we are all talking about making cell blocks. So what is the use of cell blocks? So cell blocks give better morphological diagnosis. So there has in literature they say that addition of cell blocks to smears, it increases diagnostic yield by 10 to 15%. It increases cellularity up to 15%. Better architectural details can be seen. Sometimes the cytosmears can be improperly, fixation can be abnormal. There can be abnormal staining and overlapping. It can be non-salvageable. We will come to the various examples which we can see, and this can lead to loss of cell details. In a cell block, all these things are less likely. They are concentrated, and multiple sections can be cut so that even if the details are not well visualized, next section if we cut, we will be able to see. Moreover, cell blocks cause lesser cellular dispersal. Sometimes we get hemorrhagic effusions, and in hemorrhagic effusions, we find only one or two clusters in the smears. Then we just think that let's wait for the cell block. In cell block, everything will be concentrated in one slide, in one place, and if we are able to see atypical cells, only then we will release it as no evidence of malignancy. So there are in literature they have studied the utility of cell blocks, and mostly in effusion samples. So this is one of the examples where they have compared cytology and cell block, and they have found to have increased sensitivity and negative predictive value of cell block. Similarly, again pleural effusions, a few studies are there on thyroid gland, which they have said that Combined use of cytology slides and cell blocks, they decrease the non-diagnostic rate to up to 7.1%. But all is not, everyone is not happy with cell blocks. This is one of the articles which says that cell blocks increases the turnaround time, and the diagnostic utility is low. If the results of the smears are ambiguous, only then, or if ancillary techniques are required, only then a cell block will be useful. So this is the first example. Here we are seeing a fluid cytology sample where we can see the cellular aggregate. But however, because of the overlapping, we are not able to see the cell characters of the architectural pattern so well. So in a cell block, in the same case, the cell block comes through, and we can see so nicely. We can see the gland formation, and even the cellular details, the prominent nucleoli. We can see this is adenocarcinoma, met in a pleural fluid from lung. So again, in a case two, so carcinoma, sarcoma, lymphoma, and everything can be diagnosed on a cell block. So this is again a 57-year male who presented with pain abdomen since 2 months, with a history of hematuria and weight loss. He had diabetes and hypertension. On ultrasound, a left renal mass was found with a left staghorn calculus. On PET scan, a metabolically active, ill-defined heterogeneous enhancing hypodense mass lesion was there in the middle and lower port of left kidney. So likely malignant cytology. So what we saw on cytology, on smears, we saw spindle-shaped cells with bipolar cytoplasm. You can see the cytoplasm is there on both the sides of the nuclei. And similarly on pap smear also we are seeing the spindle-shaped cells. See on cell block again, these factors are very nicely seen, and we can see a little arrangement as a little fascicles are there. So what will we call a spindle-shaped lesion in a lower pole of kidney? So a polydifferentiated malignancy. The possibility considered was a sarcomatous carcinoma or a spindle cell sarcoma. Subsequently, radical nephrectomy was done, and then immunohistochemistry was done on the biopsy specimen. It was found to be GATA positive, CK7 positive, and so it was an invasive urothelial carcinoma with sarcomatous differentiation. Now, a case 3, a 51-year-old gentleman who was already diagnosed and treated case of non-Hodgkin's lymphoma post chemotherapy. Now he had presented with query relapse for further evaluation. On PET scan, this was outside. He presented to our hospital with metabolically active lymphadenopathy above and below the diaphragm, and there was a suspicion of relapse. Overall, the features favored a lymphomatous relapse. What we received, there was a left pleural effusion also, and we received 200 ml of milky colored fluid. And this is what we saw on smear. There were lymphomatous cells, atypical lymphoid cells, and you can see some mesothelial cells in the background. And if you see there are large cells with coarse nucleochromatin. So a diagnosis of atypical lymphoid cells is suggestive of involvement in a known case of non-Hodgkin's lymphoma. Subsequently, a bone marrow aspirate was done, which showed 98% blast. But earlier it was a low-grade non-Hodgkin's lymphoma. But now this on bone marrow biopsy, it was found to be c-MYC positive and BCL2 positive, which was also confirmed on FISH in our department only, and in correlation with immunophenotyping, a report of B non-Hodgkin's lymphoma, high-grade type of 0. So apart from morphological diagnosis, we saw carcinoma, sarcoma, and a lymphoma. We can also cut many sections, and these can be used for special stains, immunohistochemistry, electron microscopy, molecular techniques, and other research materials. Anything which we can do with biopsy sample, we can do with cell blocks. And cell blocks also have a very important function as a repository of materials, which can be available after discard of primary samples. So it can be used for biobanking, it can be an archival material, microarray construction. So important point is, like, sometimes we get fluids and we are in an onco setup, right? So we have a lot of fluids, and positive for malignancy, adenocarcinoma, is fine on smears. And cell blocks we always make cell blocks on our fluid samples because these cell blocks they have a very good cellularity and they can be used for molecular testing if the biopsy has exhausted, or sometimes a patient is presenting newly. He's been a known case of say lung carcinoma for a long time, and he has been on treatment, and now he's presenting with pleural effusion. In the pleural effusion, if malignant cells are there, those can be used and salvaged into a cell block, and the clinician wants to know whether there are new mutations which have developed from the older ones. So they want to do they can order molecular testing on the cell block material, and this way the cell blocks provide a good archival material and good material for further testing. So because we are discussing only about onco setup, so I'll be concentrating on immunohistochemistry and molecular techniques. And another advantage of cell blocks vis-a-vis cytosmears is that no validation is required if we are using the same fixator. Also, like in a biopsy specimen, we have a lot of stromal material. For molecular diagnostics, especially, it can interfere, or we'll have to do laser microdissection so that we can enrich the cells within the material. So the stromal component contamination is less in cytology specimens. So there have been many sample acquisition guidelines in various journals. This is an example which tells us that cytology material if it has to be used for various diagnostic modalities, multiple passes should be done, and the samples should be collected and at the time of diagnosis, at the time of acquisition of the sample, they have to be triaged into various material. If you are suspecting an infective pathology, you should collect material for culture. If you are suspecting a tumor or a lymphoma, suppose you are suspecting a hematolymphoneoplasm, you should collect it for flow cytometry. If you are if you are suspecting a solid malignancy, please collect for cell block. Cell block is very important in such scenarios. So we come on to the use of cell blocks in immunohistochemistry. There has been an article by Dr. Upin from Hyderabad only, who has done a paper on utility of IHC or immunochemistry in cytology, and they have subdivided the various cases, saying like how these cell blocks were utilized and how it was helpful in diagnosing. In diagnosing, mostly it was useful in subtyping of a tumor. 40% of cases, it was helpful in subtyping of a tumor. Like if you want to talk about a lung carcinoma, it will help us to know whether it is a small cell or a non-small cell. In a non-small cell, after IHC, we can also do a P40 and PTF1 and say whether it is a adenocarcinoma or a squamous cell carcinoma. It confirmed diagnosis in suppose it's a small cell carcinoma and we want to differentiate it from a lymphoma. We can just put in neuroendocrine markers and confirm it to be a small cell carcinoma. It is helpful in diagnosis. Like on immunohistochemistry, we can add to prove or disprove our diagnosis. It also can alter our diagnosis. We will see in the subsequent cases. It is also useful in prognostic markers like ER, PR, and HER2. Ki67 can be used. Some predictive markers can be used on cytology. Most commonly, ALK we are using in cytochemistry. Also, we are using HER2 for anti-HER2 therapy. Like liver mets from a gastric carcinoma, they tell us to do a HER2, or a breast carcinoma, mets to a liver FNA we have done, and HER2 we can do, ALK we can do. So we are doing a lot of predictive markers also. So is cytopathology material similar to biopsy? So that question was asked, and people were asked the IHC, how many people are doing IHC on cytology specimen. This is a 2014 article. A survey was done. According to this survey, 44% of the respondents informed that IHC was done on cytology specimen. 17 different fixation. This is a problem with cytology. 17 different fixation and processing platforms were used. There is no uniformity. You know, prior to antibody reaction, they were reported, and about 60% of laboratories reported differences, but most did not. Most antibodies, most of the people did not alter their immunohistochemical methods for cytology, and validation studies didn't were not done. About 60% of patients did not have a written procedure for validation of immunohistochemical tests from cytology specimens. So, based on the survey, CAP guidelines were followed for validation of IHC. Out of these, one of the points was on cytology specimens also. If IHC is regularly done on cytology specimens that are not processed in the same manner as the tissue used for assay validation, laboratories should test a sufficient number of such cases to ensure that assays consistently achieve expected results. Like they have said in this guideline that for a non-predictive biomarker, we need to do at least 10 positive and 10 negative cases. Whereas for a predictive biomarker, we have to do 20 positive and 20 negative cases for validation of the immunohistochemical staining on cytology specimen. And to validate this, one of the journals have shown a procedure how they have done. You can refer to this article, and they have done the scoring system, and so on. So now we come to the utility of immunohistochemistry in cytology specimen. So this is a 46-year female who was diagnosed as adenocarcinoma lung elsewhere. On CT scan chest, we found a right lower lobe mass, likely neoplastic, with moderate pleural effusion. Also, abdominal CT was done, where a hypodense cystic lesion was found in the right kidney. So it was already a known case of carcinoma lung, and on abdomen we found a cyst in the kidney, and there was a pleural effusion, 300 ml of the reddish color turbid fluid we received. What we saw was these kind of cells. They looked quite bland with abundant vacuolated cytoplasm. There were nuclear hyperchromasia at places, but the NC ratio was not that high. So we just said atypical cells seem suspicious for malignant effusion. Query primary, we didn't know whether it was kidney or lung. So thankfully we had cell block, and cell block B cells were there. So first of all, we performed a BURIP2, BURIP4 and calretinine. Calretinine was negative and BURIP4 was positive in these cells. This was followed by markers like CK7 and CK20. CK7 was found positive and CK20 was negative, and TTF1 showed good nuclear positivity. So with the positivity of CK7 and TTF1, we diagnosed this as a case of malignant effusion of pulmonary adenocarcinoma. Although it was a pleural effusion, in known case of carcinoma lung, everything is fine, but morphology was not very typical, and also because we found a cyst, we also wanted to root out a kidney neoplasm, and IHC on cell block was helpful. Another case was a 30-year male who presented with a left-sided pleural effusion. So on ultrasound chest, they found the pleural effusion measuring 70 to 800 ml, but also found a small soft tissue mass lesion on the right side of the chest, which was associated with adjacent rib destruction, and diaphragmatic movements were normal. So there was a dilemma. There was this pleural effusion where most of the cells were like mesothelial cells, but there were these smaller cells which were looking atypical, right? These were loosely cohesive clusters of mesothelial cells, and these were our cells of interest, which were dark and small. Again, on higher power view, we can see that these were mesothelial cells, and these were smaller cells, which are having high NC ratio, minimal cytoplasm, focal vacuolations we could see. There was a mixture of small hyperchromatic cells and larger cells with little open chromatin, and so we were seeing some small round cells. Now again, similar another picture showing the highlighting the same. This is a Capstan Smear. Same features were seen in the smear. Now, uh, so what was the diagnosis? What were we dealing with? So it was a malignant effusion with round cells. Now there are endless possibilities with round cells. They can be small round cells. They can be large round cells. So small cell round cell tumors can be. Remember, this is a young patient, 30 years old, with pleural effusion and ipsilateral rib lesion or a chest wall nodule. Whether it was lung going into rib or rib going there, we didn't know. So we had all these DDs. Uh, in general, we didn't have these DDs, but in general, round cells we have these kind of things. So multiple things can be there. On a FNA smear, we have certain patterns, right? All right. So this is a case of lymphoma. This is a case of Ewing's sarcoma. These are more uniform with a fibrillary background and a triple chromatin, a neuroblastoma. Again, a rosette formation in the neuroblastoma, and these are ganglion cells in a ganglioneuroblastoma. So we in an smear FNAC smear, we still have some features to fall back or fall back on. In all these features are lacking in a effusion specimen. We can't see those changes in effusion specimen, especially the background is missing. So what further? We went back to the history and again we thought, what was it? So uh, like that there was a lytic destructive lesion involving the anterior third of the right eighth rib. So a biopsy was done in the meantime. Apart when the effusion came, after that biopsy was done. Based on morphology and site of presentation, we consider the possibility of metastasis from either a neuroendocrine tumor of the lung or a Ewing sarcoma because they were round cells. Then, in the meantime, the cell block also came, and we were seeing the same small round cells, and the cellularity was good, quite good, thankfully, so that we could have done any IHC if required. In the meantime, the biopsy from the rib mass was ready, and it again showed the similar features. And we also told them in the pleural fluid also we are showing the similar features. IHC was done, where what we were thinking we told them, and synaptochroma was negative, and CD99, Fly1 and NKX2.2 were positive. So what is the diagnosis? It was an Ewing sarcoma. So we went ahead and did immunohistochemistry on the fluid also. They were also CD99 positive as well as NKX2.2 positive. So final diagnosis was malignant pleural effusion with round cells secondary to Ewing sarcoma. So these are all highlighting that this here IHC was performed to subtype the tumor, right? So here we come to the next case number 7. Now a patient was evaluated for generalized weakness, and incidentally he was found to have a right renal mass. So CT scan was done, and a exophytic mass was seen in the inferior pole of the right kidney. This mass was extending above the inferior polar line. No evidence of collecting system or rectal vein or artery invasion was seen. The CT scan diagnosis or the radiological diagnosis was a renal cell carcinoma. The renal nephrometry score was 7. FNAC was done from the right renal mass. What we were seeing, this was a 55-year-old male. I didn't mention the age. This was a 55-year-old male. And what we are seeing were these small, they were round cells. Okay, round cells. Focal acinar formation was seen. We can see these round cells were there. Little acinar formation was there. More amount of cytoplasm was there elsewhere in the slide. So neoplastic lesion of round cell origin. Possibilities considered were papillary renal cell carcinoma and metanephric melanoma. It was an older individual, so we didn't consider Wind's tumor, and moreover there was no necrosis, no mitosis. They were looking very blank. So these were the two considerations we had. And cell block, again, thankfully it was cellular, and we could see a lot of dispersed as well as aggregates of cells. And if you see, these aggregates were forming a few tubule and glandular appearance. Here also we can see the glandular formation is seen. So architectural features were seen on the cell block. And we went ahead and did IHC. These cells were CK7 negative, MCR was negative, WT1 was strongly nuclear positive. So with these findings, this is how we diagnosed this as a case of metanephric adenoma. And these are the differential staining patterns which we can see. These are the differentials: metanephric adenoma, papillary renal cell carcinoma, a Wilms tumor, which we did not consider because IHC is not useful. It is the morphological features which are used to differentiate metanephric adenoma, and also the clinical features from this Wilms tumor. So WT1 and CD57 were done, and today only we got the resection specimen from there, and these are the slides from the resection specimen, which is showing classical morphology of metanephric adenoma. Less than 20 cases have been reported on cytology, cytological features of metanephric adenoma. And the IHC in the today only we received the section, so IHC is being performed. Results will be eagerly awaited by all of us. But it's a morphological diagnosis. With this diagnosis, it is a metanephric adenoma. A 64-year-old gentleman in case number 8 was evaluated for lower urinary tract symptoms and was diagnosed to have a carcinoma of prostate. The PSA level at that time it was 594 nanogram per ml. He also underwent CORBT for bladder tumor with bilateral scrotal orchidectomy. The PSMA scan at that time revealed multiple non-regional nodal mets. So this was in year 2019, and ever since he was on abiraterone since then. In 2021, he again presented with a PSMA scan was done. PSA was normal, okay, and a CT scan which revealed a normal sized prostate, but however, it was avid on PSMA, which was likely residual lesion. Similarly, many nodes were there which were likely to be metastatic. There were bilateral lungs and liver lesions. Now, these lungs and liver lesions were likely metastatic. Here PSMA activity avidity was not there. So possibility of metastasis from carcinoma bladder, because there were only two primaries here. So because it was not PSMA avid, they were thinking of carcinoma, mets from carcinoma bladder. So there was no other evidence of PSMA disease in the body. So now what did we get? Now this is what I was talking about, that the smear sometimes can be very badly processed. It is done in most of the FNACs are done by radiologists in our setup, and the delayed spreading of material is there, but it is all caught up in the clot. Hardly anything we could see, but we were able to see some atypical malignant cells. They are also being caught up, and few cells in Pap smear were showing these features. But what we were seeing were these were small cells, right, with minimal cytoplasm. So if we had to think between a urothelium and a prostate, what would we think? We would think of a prostate because they are small cells, right? So again, our cell block came to our rescue, and we could see these cells. They were smaller cells with minimal cytoplasm, and we said that on FNAC we said positive for malignancy, suggestive of metastatic carcinoma. Whereas on a cell block we could say it is malignant carcinoma, and now because we had the cell block we could suggest IHC. So it was built, but most of the stains, like it's all blue, so most of the stains came out negative. CK7 was negative, CK20 was negative. So because CK7 and CK20 were negative, we were thinking more about prostate than bladder primary. Again, but because the suspicion of the radiologist was very strong, because it was non-PSMA avid lesion, we did GATA3. We also did P53 after consultation with our colleagues. What to do. We want to rule out morphology. I was favoring more prostatic origin, so that was also not there. And we didn't have NKX 3.3 that time, and so only MCR was available, and it showed a very faint cytoplasmic positivity. So based on these findings, we gave it as focal cytoplasmic positivity in MCR and all negative, because CK7, CK20 negative was also supporting a prostatic origin. Morphology was favoring a prostatic origin. So we said that these IHC and morphology features favor metastatic adenocarcinoma from prostate primary over urothelial primary. But there were red herrings. Nobody was happy. The clinician was not happy. The radiologist was not happy. And we were also not very happy with the staining pattern. So the serum PSA was also normal. PSMA scan also normal. So it was discussed. So the pathologist, medical oncologist, and radiation oncologist discussed. And after discussion, this is what we got. So what all blue stains had turned into all positive stains. So what did we discuss? So this is CD56 on low power and high power, synaptophysin and Ki67, which was highly positive. So what was this? It was a neuroendocrine carcinoma. So wait, what do you think it is? So it is a third primary from the liver, or it was already a prostate cancer, then urothelial cancer. Now is it a neuroendocrine carcinoma? So no, it is an androgen deprivation causes induction of neuroendocrine differentiation in the tumors, and this has been well documented. So a patient on anti-androgen therapy can develop neuroendocrine differentiation, which was found in this case, and it was done. Now we come to almost the last part of our presentation, that is molecular markers on cell blocks. Can we do molecular markers on cell blocks? So yes, we can, and in the last few years, there has been an exponential rise in the targeted therapy as well as the target biomolecules which we are detecting, and there has been a corresponding increase in the number in the techniques by which we are able to detect these, and these are the FDA approved targeted therapies in solid tumors. So, so there are many guidelines which are available for molecular testing on tissue biopsies, but they are a little lacking in cytology. But whatever is available, I have put it up here. So, according to these guidelines, the smears, the cytosmears have a advantage that they have no formalin fixation. Because no formalin fixation is there is no cross-linking, and so a better DNA quality can be obtained from smears. In fluorescent in situ hybridization, smears are good because there is no nuclear truncation artifacts, which you can see in sections where a 3D cell is cut into two number of fish signals per nucleus can be counted. The disadvantage is that if we use one smear, with which we have diagnosed a cytology sample, we have to use the same smear for fish or for molecular diagnostics. So that will destroy the original slide. So it can lead to medical issues. Moreover, smears, the IHC is suboptimal because formalin is not used, and the validation studies can be there. So still, cell blocks are usually needed. So cell blocks have a little advantages because operational simplicity. As I told you, most of the guidelines are on biopsy, and cell blocks are akin to biopsy. So the cell blocks solve most of our tissue. So morely, there is no destruction of diagnostic slides. They can cut multiple sections and use it for molecular diagnostic tests. There are disadvantages like that which I told you with cell blocks. There's high variation in fixation materials and techniques which are used. So again, validation has to be done, or a standard guideline to tell that this is the way we have to process the cell block has to come, which is not yet there. So like lung biomarker testing, there has been one in 2013 guidelines. They were saying they recommended the use of cell blocks because of the reasons mentioned above, cell blocks over smears. But in 2018 guidelines, they have said that you can use either cell blocks or any other cytological preparation as suitable specimens for lung cancer biomarker molecular testing. Similarly, for colorectal biomarker testing, cytology specimens may be adequate for testing, but will require proper validation is the key. So now I present a few last few cases on which cell block material was used for molecular testing. So, patient, 66-year female presented in March of 2020 and was evaluated for complaint of abdominal pain and was diagnosed with carcinoma endometrium. So she underwent total laparoscopic hysterectomy with lymph node dissection, mastectomy, small bowel resection in April. In view of high-grade tumor with myometrial invasion of more than 50%, she was advised adjuvant therapy, and she was given chemoradiation of 4 cycles, which was completed in September 2020. In March 2021, now she presented with ascitic fluid, and ascitic fluid was found to be positive. Now, with this, the clinician advised molecular testing for MMR proteins, 4 mutations, as well as HER2 new fish. HER2 new fish was performed. So this is on that cytology cell block specimen. So we can see that this is a nice cell which is having 2 red and 2 green signals. We use cytovision, and this there was no amplification. So the ratio was 1:3. So the interpretation was it was negative. This is just to show that we can do all kind of molecular testing on cell blocks. So again, this is a 65-year-old female who was found to have an incidental space-occupying lesion in the right lung, which was when she was undergoing screening. So on PET scan, again, there was a hypermetabolic lesion. Right upper lobe biopsy was done, which showed a non-small cell carcinoma. So in 2019 only, she underwent resection of right upper lobe lung mass. But in 2021, there was a right lung hilar region mass again, and there was effusion, and it favored a recurrence. So effusion is always a easier specimen to obtain. So pleural effusion was sent, which was positive for malignancy, and it had malignant effusion. The cell block was also there, so it was the patient was advised EGFR testing for further management. The EGFR testing showed positivity for deletion 19. You can see the curves. The CP value is 29, which is within two counts of the control, and this was found positive. This is a graph which is showing EGFR wild type. No known mutation is found in this one, just for comparison. So case number 12 was a 46-year female, a known case of carcinoma lung since 2019 on chemotherapy. In already a known case in January 2021, again she presented with recurrence. She was advised molecular testing by NGS, this time to find a target molecule, and they performed a lung and colon NGS panel. And in this NGS, EGFR mutation was found, which was PL85 858R and deletion. And the variant allele frequency was 2.8% with a coverage of 2822. So after this NGS, the patient was started on TKI therapy, and there was a decrease in the size and metabolic activity of the tumor cells. So this is how I end this talk. So the take-home message from this lecture should be that they are indeed a bridge between cytology and histopathology. So if we are practicing cytology, cell blocks are a way to go, and they can provide whatever we can do with histopathology specimens, we can do with cell blocks, provided again there are caveats. So in this era of molecular diagnostics and minimal invasive procedures, the cell blocks provide a reliable source of material, provided proper sample acquisition and quality validations are performed. They are easy to prepare. Cell blocks are easy to prepare in all laboratories. So a standardized approach to fixation and processing of cell blocks is a need for of the hour, and there should be guidelines which should be there. So I thank all my teachers and all my department for helping me in preparing this presentation. Thank you. I'll be happy to answer any questions if any. Back to you, ma'am.
Yeah, the presentation is open for discussion. I think the questions will subsequently follow. So what I just want to compliment Dr. Harveen for a very, very lucid and detailed presentation, starting from basics, all about cell block, the minor accurate details, and taking us right till NGS. And perhaps in the next lecture, she'll talk about biobanking also. You can clearly see that she's put in a lot of effort in making the slides, and a very strong in-depth knowledge of histopath is equally important. So she has actually made me really proud when I see my students being so renowned and speaking so well. I compliment you for your excellent cases. And what I appreciate is that there has been a lot of teamwork, which I can see that you have worked in collision with Dr. Vishal, and you have been aware of the limitations of cell blocks also, being guarded at times and taking clinical inputs, which is the message that I would like to give to everyone here, that interacting, having tumor boards, taking clinical inputs, tumor markers, imaging, PET, and then following an algorithmic approach will invariably lead you to the right answers. And always be humble, because anyone can make mistakes. We don't do that. We can make errors of judgment, but really, Harveen, for a guide, there is no pleasurable moment. For me, it's a golden moment to see a brilliant girl flourishing and becoming so, so knowledgeable, both with a very strong histopath backup. I could see that the backup was strong, and that's why you could relate to the latest markers. And in fact, we also don't have NFK2, so it's. I can see that your institute is really going forward in the right direction. And some of your cases I would love to share, because this morning itself I had a similar neuroendocrine carcinoma of the prostate. So, and your cases had synchronous, metachronous malignancies. So you really have captured it well and put it together with clinical inputs, making it extremely knowledgeable and giving a lot of take-home messages to our youngsters who will probably take up cytology with your inspiration. Thank you so much. And thank you, team Nilam, Dr. Syed, Dr. Rao, and of course, my dear little Harveen, whom I can see the brilliance and the passion is going on and on. And well, I must admit that the passion still remains with me also.
Thank you, ma'am. You have been an inspiration, and even Dr. Sushila, who has guided me in this institution. She has guided me from a scratch, literally hand holding me and making me flourish. So I can't.
So is your NGS in-house?
Yes, ma'am. It is in-house, ma'am. NGS is
and do you charge for antibodies on cell blocks and on histopath?
Yes, ma'am. Yes, ma'am. Separately.
The problem we face is on that double charging.
Yes, ma'am.
I can see that your institute has successfully managed to convince the patients.
Yes, ma'am.
And we don't repeat, madam. We don't repeat the biopsy if it is good enough in a cell block.
Okay.
So we don't repeat. I don't repeat again on a biopsy.
Like ma'am,
because you really repose faith in your cytopathologist, which is yet another compliment to Harveen. Yes. And well, in our institute, I don't think we're doing that, because the patients actually don't land up paying twice. So we land up doing it more on histopath, actually. Or core biopsies,
It all depends on the clinician also, ma'am, and also the collaborative. Like today's case, like hysterectomy, that nephrectomy has come, and that Dr. Vishal is going to report. So we always see each other's slides. Okay, you have done this. We might not repeat those markers, and we might do other markers. If the cell block material has, exhausted, then like every case has a different, flavor to it and different.
Excellent. It's continuous learning with the teamwork.
Yes, ma'am. Yes, ma'am.
Thank you so much.
Thank you, ma'am. Thank you for the very kind words. It's always good to you have been our inspiration.
Thank you. I feel humbled with that compliment.
Thank you, ma'am.
Thank you.
Thank you.
Right, ma'am. Thank you so much. Wonderful presentation, excellently done. So knowledgeable and so much of hard work in trying to come to the conclusion. I've had the honor of visiting Dr. Basavatarakam as an NABL auditor for histopathology and cytopathology. They have a wonderful team, and had the pleasure of meeting Dr. Susila and Vishal and everybody. They have a very wonderful setup, and they do a very good job. In fact, I had also visited Apollo Indraprasth long time back as an NABL editor for histopathology as well, and that's a wonderful place.
Thank you.
And before I close down this session, ma'am, I would like to take the opportunity of requesting you to come on this platform and share your experience. We would be, waiting for that. We would love to have you on the platform and share your oncopathology experience. I will get in touch with you, and then we can organize it sometime when you're free. And we would be, more than happy to have you here and share your experience, and everybody will learn after that.
That would be my privilege. Thank you.
Thank you.
Yes,
Thank you, Nadine, sir, for
pleasure is all ours.
thank you, sir, for providing this.
Thank you, Dr. Harveen. Excellent. We will be sharing the edited video of this with everybody, as it will be on the YouTube as well for everybody to see and learn. A wonderful presentation on cell block, a complete unit in its totality. Thank you, Dr. Vishal, for joining, and everybody else for joining as well. Dr. Akila and so many people on YouTube. Thank you. Then bye-bye. Thank you. Good night. God bless everybody. Take care. Bye.
Thank you, sir. Thank you, sir.
Thank you, ma'am.
Thank you.
Thank you.